Venki, and you
Okay,
are
guys, we
live.
crossed the lesion. You know, the blood, I'll give you the history in a second, and we'll talk about it. As you can see in the picture, this is a very tight lesion here. It's mainly in the internal. Balloon up, please. Blood pressure is 152, heart rate is 77. We're taking the balloon up.
Balloon up.
Yep. Balloon down.
Down.
Tolerated beautifully. Okay. Take this balloon out. Hold this. And can you just keep it live? Watch that wire, please. Yeah. Okay, so 84. Chris, can you put up the slides in the minute? Okay, hang on for a second then. Let me get this balloon out of here. We'll take a picture. Heart rate, pressure is all good. Okay. Give me some hip saving. Okay, so we used, on CT scan, the common carotid measures approximately 8.2. The internal carotid measures close to 5 or 5.2. You got some contrast? Yeah. Let's take a good picture of this now, same angle. This is post-balloon angioplasty. Yeah. Okay, you ready? Shooting. He moved. Do it again, please. So that's your post-balloon angioplasty. So let's freeze it right there. Average flow reversal time, is like 6 to 8 minutes, and then I had one that was 60 minutes. It's really bad carotid, but generally you can finish this within 30 minutes, 38 minutes like people do the PTABs here.
Venki, what's the logic of
go.
doing a post-angioplasty angiogram? What does that help you with?
Well, whether I dissected it, I know that. Whether I dissected that carotid with the balloon, do I have to extend my, the stent? So I think it gives me a good picture. And once you get the flow back into the internal, like please, once you get the flow back into the internal then fills up pretty nicely, and you may even change your stent size or even things like that. So what's that sheet? The reason I want to present this case is transfemoral carotid stenting. Okay, this is a question here. How many would just land this stent just in the internal and the proximal internal? This is a 9/7 stent, and just land it right here so it doesn't come into the common? Or would you just land it and put a second stent into the common?
How long of a stent is this, Venki?
It's a 9/7/40, standard length.
Okay.
I think if you deploy it there, Venki, it's going to open up, the proximal end is going to
Nicely.
open up where the torsion point in the carotid is. So either you
Yes.
have to be
So
higher,
I'm
which I
gonna
don't think you
like-
can, so I think you got to deploy there, extend into the common. I don't like to have the stent sitting right where the bifurcation
In the
is.
internal into the what if I land it here?
I would come back a little bit.
We'll
to
see.
line a
We'll see how it looks. I don't want to
toward
go
the common a little more,
any higher than
just for
that,
the-
yeah.
Yeah,
Yep, that probably can get away with.
I would extend to the common and line a little short on the internal carotid.
I'm going for perfection. Maybe not.
There you go.
Okay. Let's see. Blood pressure is all good. Everything looks good. Let's take this wire out. I'm not a big fan of post-stent balloon angioplasty, and that is where I think the new NeuroGuard and the Contigo systems, they're most saline first. They're most focused on this post-dilatation expansion. Can you wipe the markers off, please? Okay, let's take a picture and see whether we need to extend that into the common or just leave it for now. Saturation's all good, everything will look good. Okay, here we go. I'm shooting a good picture. Let's do it again. Someone did hit the table. Okay, let's get a good picture here. Okay. How many you want to extend? How many you want to leave it?
Leave it alone.
Yeah, I would leave it there.
I think we landed it right at the origin of the internal, which was actually relatively normal. and we got about a centimeter above the lesion. Get me another view. Let's take another view and then see. I know that's another thing. If you're not too concerned, you just take a couple of views and then go from there. Yeah, go AP. Take your marks off, please. I think that's not bad, Anthony. Come a little low. Drop your eye down a little bit. Yeah, I think we can just leave it there.
Good. Yeah, that looks good.
I don't think we need to put a second stent here.
No, that looks good.
Okay, let's undo the flow reversal. Everybody happy? Audience? Do you want to touch it up with the post balloon or no?
No.
No.
No, okay. So let's go to the slides. And we'll have a little, so this was an 84-year-old male patient, almost a 90% in the internal. He had a history of a TIA, no strokes, vision loss, anything. He was actually undergoing intervention for elevated future stroke, hypertension, hyperlipidemia, pulmonary embolism, DVT. He is on Eliquis. So he did have a TIA. So he's a symptomatic 80 to 90% stenosis of the internal. Go next. High-risk criteria. Obviously, you can always do endarterectomy, which is an option. Go to the next slide, please. This is his CTA, and this is, I think, where... So if you look at those pictures, and if you can make that bigger, you will see the extensive tortuosity of not only the carotid, the common carotid, but also the brachiocephalic, innominate, and the takeoff of the subclavian. It is almost like a figure of 8. And so this is my argument to why TCAR is a better option than transfemoral carotid artery stenting. And this debate has been going on for a very long time. And crest to, Dr. Aburama, you may have to summarize for us why CAS is now touted as a better option. For me, I think TCAR avoids manipulation in the arch. And with this lesion, I think you'll be manipulating it. You'll put a buddy wire into the subclavian, try to get into the carotid. Too much of manipulation. That's one reason why I think TCAR just eliminates that part of it. The second one is you're crossing the lesion without protection, And so those are the two main reasons. I'm not saying transfemoral carotid artery stenting has no role, but I feel the role is actually very limited. And so that is the argument we are making. I was part of the study, for the Performance 3. The question then was, and the whole determination of using a filter and a balloon and a stent, like a 3-in-1 system, even though we did do reversal of flow, is this the ideal way? Because sometimes, the reversal of flow is really good in the main branches of the internal and the common carotid, but apparently the reversal of flow higher up in the brain is not as adequate, and therefore you may still get embolization, and therefore the flow reversal is not completely 100% just with reversal of flow. So this combination of a filter, reversal of flow, balloon, and stent in one, can you explain the argument for how we should use it? And if and when it is approved Performance 3, it means you have reversal of flow, and then you go ahead and put a filter, balloon, and stent at the same time via the transcarotid option. So this is where the argument is, have we reached the optimum level of comfort in the regular TCARs that we are doing? So with that, you all discuss, I will listen, and let me get this off so that the patient can leave the room and we can start the next case. So thank you so much for your attention.
Thank you.
Thank you.